vital in understanding the genesis of anterior segment dysgenesis. So Dr. Sushmita, please.
Good afternoon. Thank you. Thank you for the invitation. I apologize for the slight delay. Right. So we start with embryology of the anterior segment dysgenesis. And in the next couple of minutes, we'll see how does the angle develop? How do we recognize dysgenesis? Why does dysgenesis happen? How early can glaucoma develop? And what options do we have for management? So, childhood glaucoma is really like an ocean. It's similar. Once you've diagnosed childhood glaucoma, what next? This is the conglomerate that we'll be in. This is the CGRN classification. So, the primary glaucomas and the secondary glaucomas associated with non-ocular conditions or ocular conditions. So, non-acquired ocular, non-acquired systemic. So, this is the whole basket of clinical entities which are a result of these anterior segment dysgenesis. So, what is it and what is a normal infantile angle? So, the normal infantile angle looks like this. There's a flat iris insertion. The ciliary body band is usually present and it's a very translucent trabecular meshwork, though the stroma is not well formed. But then you have an iris, major arterial circle, and the radial vascular pillar. So, you can see that. And to see that, basically, you need a direct gonioscope. You need to turn the patient's head to the other side and then gently put the gonioscope on the patient's eye. And then you'll be able to visualize the nasal angle. And on the picture on top, you see that the microscope also needs to be tilted. And thanks to the MIGs, a lot of people have actually started doing this. So we hope it will translate into people also looking into the eyes and looking into the angle of babies. Coming to the normal angle development, what usually happens, and this is a busy slide, but at 5 months gestation, there's a continuous layer of endothelium which covers the angle. So this is what we are like. Now, this green thing is the trabecular meshwork, and this is the uveal tissue. So it's completely covering it. So there is no outflow. Basically, this is because the ciliary body hasn't developed and there's hardly any inflow. So there's no aqueous. So that's the protective thing, that there is no way that the fluid can go out. And then in the third trimester, the endothelial layer progressively disappears. It starts going back, receding, and then the peripheral uveal tissue begins to slide back, and development of the trabecular lamellae and intertrabecular spaces begins. So this is the trabecular lamellae and intertrabecular spaces. But remember, there is continuous development of this trabecular meshwork till almost a year of age, and the normal AC angle is only formed then. The clinical significance of this would be in the fact that early lens extractions, because the lens, remember, is a regulator of trabecular meshwork dysgenesis. Right, so somebody's just changed the slide. Anyway, why are you changing my slides? नहीं, आई एम नॉट चेंजिंग, मैं कुछ नहीं कर रही हूँ इससे पहले. Right. So what I was saying was the lens is a regulator of trabecular meshwork development. And if you take the lens out early, then the trabecular meshwork development is arrested. Now, the clinical significance of that is in early cataract surgery, resulting in more glaucoma. The vitrectomy for ROP resulting in glaucomas. Now, once this has been recognized, the lens sparing vitrectomies have drastically brought down our ROP related glaucomas, as well as the IATS, which has come out with early cataract surgery or infantile cataract surgery prior to 6 months of age. So, most pediatric ophthalmologists, at least for bilateral cataracts, would like to delay it till about 6 to 8 months, and then the incidence of glaucoma is much less. So they're all related to the development of the anterior chamber. The other thing to remember is there is a development of outflow channels. So it's not enough for just the trabecular meshwork. So again, if you see this is just a Schlemm's canal is a 1 lumen at about 12 weeks. And then as the baby grows in utero at 26, 33, and 36 weeks, the outflow channels are developing. And they are finally developed only 2 months after birth. The other clinical correlate of this is why in neonatal onset glaucoma, If you just do a goniotomy, it doesn't work too well. Now, that's easy to understand if you look at development. They don't work too well because the outflow channels haven't developed. So, there's no point in just taking out trabecular or dysgenetic trabecular tissue. If they don't have a channel to move out, they're not going to work too well. So, therefore, the infantile glaucomas work so well. So, if you have a child who you're going to operate maybe at 3 months or 4 months or 6 months, those are the goniotomies, the garden variety infantile glaucomas, which are really going to work. So the neonatal onsets may not clear so well, but the infantile onsets are the one which you would want to target with doing just an angle surgery. So then what does the pathological angle look like? This is, remember, the normal AC. This is what the pathological angle would look like. Lots of iris processes which are covering the trabecular meshwork. And Sampaolazzi looked at a type 1 and a type 2 angle. Now, Sampaolazzi, this was at a time in the 60s when there were no gonio images, there weren't even microscopes. They used to operate with a handheld light and a loop. But even with that, he actually made drawings of every goniotomy that he did and asked a simple question: why is it that some goniotomies work so well and why is it that some goniotomies don't? So he took those children, he went back to his drawings, and what he saw was that in the children the goniotomy worked, the angle was something like this. So there was some trabecular meshwork, whereas those in which it didn't work, the iris hadn't receded at all and the trabecular meshwork was completely covered. So he classified that into a type 1 and a type 2 angle where the trabecular meshwork is visible and a trabecular meshwork is not. So it would be well within a logical consequence of this is to look at the angle before you do surgery. And if you have a type 2 angle, maybe at least keep it in mind that this is unlikely to work even if you're going to do a goniotomy, or maybe just plan an outflow procedure like a combined trap with trap. So, anterior segment genesis is a group of non acquired ocular anomalies with developmental abnormalities of the anterior segment where many genes, development of the ciliary body, lens, iris, cornea, everything is available, and the abnormalities affect multiple structures. And typically, they include combinations of iris hypoplasia, corneal opacity, and angle dysgenesis in a whole package. So these are the various combinations. I won't go into the details. This is the normal. Okay, so the underlying abnormality, usually in most of them, is genetic, and some of them have been mapped to different disorders. PITX2 and FOXY1 for Axenfeld, PAX6 for aniridia, and a whole lot of genes for Peters abnormality. Of course, there are overlapping clinical signs and genetic variants, and then there are mixed phenotypes. So, non acquired glaucoma stems from an embryologically abnormal trabecular meshwork, and it can manifest in myriad forms and multiple etiologies depending on the development, but genetic influences play a major role as well. Thank you.
Thank you, Sushmita, for a very informative talk. So, I think the infantile angle is very, very immature and it keeps developing till the age of 1 year. And that is why, if the cataract surgery is performed before 3 months of age, when the angle is not yet developed, there are more and more chances of developing glaucoma. So, with that, now I will now invite Dr. Kirti Singh. She will be speaking on a very important entity, Axenfeld-Rieger syndrome. And I'm thankful to Dr. Kirti. I think she has replaced Dr. Ramanji Sihota at the last moment. So thanks a lot, Dr. Kirti.
You can't refuse Dr. Ramanjit when she asked you to do something, and I could. They're very big shoes to fill, so I'm not sure I'll be able to fill them. And so my topic given to me was anterior segment dysgenesis and glaucoma, and as has been beautifully covered by Dr. Sushmita, the embryology is so clear, and this George Burring's classification from the very beginning still holds true. So going to talk about the secondary glaucomas, the glaucomas associated with non-acquired ocular abnormalities, or the AST, or the anterior segment dysgenesis, and a bit about the Sturge-Weavers. And as per the new classification, as has been just discussed, this is the Congenital Glaucoma Research Network, or CGRN classification. Now, pathology in ASTs mostly is the abnormal neural crest migration. Now, neural crest, as you can just remember, that forms the 3 layers of the cornea, endothelium, corneal stroma, and 1 layer is over the iris and forms the trabecular meshwork. And disruption of the resorption of the parietal endothelium covering the cornea with contraction subsequent and iris changes is the one which
Sushmita,
causes these
Sushmita.
ASTs. In addition, neural crest cells also form the forebrain, the upper face bones and cartilage, and dental papillae. And that is why the neurocrystopathies or the ASTs would have some features of the maxillary hypoplasia and anodontia and the forebrain problems. This has been already covered, and now I'm going to cover the axon field triggers. Just to recapitulate, anomaly is just the posterior embrytoxon. It is invariably temporal, sometimes total. It's an anterior displaced Cholbis line with iris strands. Rigors, if it is a step further, it has, in addition to axon field, iris hypoplasia, correctopia, polychoria. It can be in different phenotypal variations, and it has iridocorneal adhesions. Whereas a syndrome, moment you say it's a syndrome, it has systemic defects. And as we will discuss the neural crestopathies, because the neural crest forms the dental papillae, you have hypodontia, dental anomalies, maxillary hypoplasia, hypothyroidism, empty syndrome, and classically with PTEX2 classified with mutations, you find periumbilical abnormalities in hypodentia. So PTEX2 is the one which was linked most with rigors. It's a bilateral disease. It's autosomal dominant with variable penetrance. Family history is usually positive, not always, and these 4-5 genes have been linked to it. Glaucoma occurs in almost 50% of the cases. It is slow to develop because the membrane contracts and the trabecular meshwork gets disrupted. So it manifests in the first to second decade, less often in infancy. The abnormal iris tissue is over the trabecular meshwork. You have pannus, you have iris translocation defects, you have macular degeneration in addition, and you have the spectrum of disorders. So the thing is, this just gives you some time because these patients, when they come, you really can't mistake the diagnosis. It's not a clinical dilemma, but the surgical dilemma still remains. The next spectrum is Peters. Now, Peters is the problem with Peters is the glaucoma comes at birth. It is type 1 and type 2 with the central corneal opacity with all corneal layers and synechiae, and type 2 has a lens implication. And UBM has made things easier by telling us exactly where the lens adhesions and the corneal adhesions are there, because most of these patients have corneal opacity which is dense enough to preclude any visibility. Now, this is usually sporadic, may be autosomal recessive, and the similar genes of PAX6 and PTEX2 have been implicated. It has classically defects in the descendants and sometimes in the endothelium and the Bowman's too. So, layers of the corneal are absent, and that is why it causes opacity and anticorneal adhesions. Peters plus is something which we have to look for, especially they have children have short stature, brachydactyly with ear and heart anomalies because of rhizomelic shortening, something called a short syndrome, short stature, hyperextensibility of joints, inguinal hernia, ocular depression, Rieger's anomaly, and delay in dental eruptions. I'm not trying to make given MCQs in these, but it's important to know because when you see these children, you have to be aware of these things, and unless you know it, you will not look for them. So if you that's why it's important to know that these syndromes are associated, and you have to get them ruled out. Aniridia comes later in the spectrum, but it has also with the PAX6 gene, it's an autosomal dominant with incomplete inheritance, incomplete expression. Now, here you invariably have microphthalmos. Cataract is very often present with Zonder issues. Wilms tumor is the systemic association, intellectual disability may there, and it has been linked to the chromosome 11p deletion. If that is there, then these children have a 70% chance of developing Wilms by 3 years. So again, the prognosis of these children is decided by that genetic tests. Wagner syndromes and GLPs and diabetes are associated and they have to be ruled out. The anonymity has protein manifestations. It has classical keratopathy and limbal cell deficiency manifesting as pannus. And this is important for the glaucoma surgeon because this can give rise to failure of trabeculectomy. It has meibomian gland dysfunction associated, iris hypoplasia, invariable photophobia, cataract with superior ectopia lentis, just like Marfan's, but these annuals are definitely poorer. There is foveal hypoplasia, so even if the cataract and the glaucoma are controlled, the nystagmus and the vision may not go away, and this is loss of foveal avascularity and impaired color vision. Glaucoma occurs here again late in childhood by 13 to 50 years in 50 to 70% cases, and here it is progressive angle closure by rotation of iris stump. The iris plane literally tilts from the pupil to the vertical. It can be mild, moderate to severe. In the management of most of the glaucomas of ASD and aniridia is aquasuppressants. You may try prostaglandins, but the aquasuppressant work best. Goniotomy has poor results because the membrane is there or the iris turning is there. So invariably you have to have trabeclectomy, trab and trab or trabeclectomy. It has high risk of shallow and flat anterior chamber and it has complications. Aniridia in itself is a profiabric disorder, and as I said, limbal cell deficiency and poor tear film will give rise to bleb scarring. So some people prefer the tube shunt. This is I didn't have a video of an Axenfield rigor as asked by madam, so I'm just showing you someone which is a primary congenital glaucoma because it is some features are similar. This is a very broad vessel coming, and this vessel was very dilated. Actually, you could see the aqueous going through it, but it was dilated, and we were worried it's going to bleed. And this is the mitomycin technique of the Mofield technique of mitomycin, which is there with everybody. So I'm just going to be a little. So I would still try a Harms trabeculotomy. Now here I tried a different procedure. Once you do the trabeculotomy, I very often found one side is easy, the other side becomes because of the shallow AC or the collapse of the AC, it becomes a wraparound iris configuration. So I'm trying to form it and do it again, but you never try to push the trabeculum. So I go the reverse way, from inside out, and that invariably works. And then you follow it up with the inner sclerostomy and large PI because that's important. And the bleed would be there very often. Don't get worried about that. And what I do instead of releasables is I do surrogate releasables. I use Ato or Vicryl to use, and these are the surrogate releasables. I assume that after 2-3 weeks they'll lose their tension and strength, and they'll behave as releasable. And I do titrate on table these children with this little titration from the side port. So these are the 2 surrogate releasables I've tied. And this is the little flap titration. And then you have the conjunctival suturing. We do the conjunctival frill suture, which has been popularized by our team for the last 7-8 years. Now we are doing this. But yes, we do need to check these children after 3 to 4 weeks, do an EUA. But this suture surprisingly doesn't cause any problems. So just 2-3 slides more. Some case vignettes of Axenfield rigor, which I try to dig out from my repository. So this was a child we operated at the age of 13 years, and she's doing good. She came for a visual disability certificate because she's applying for a job. This was a 28-year-old operated trab at 10 years of age and seems to be doing well. In fact, the trabs which we done before are doing better than the trabs which are doing now, and I think this is a common problem because of mode of use of prostaglandins. This is a Sturge-Weber child, and I'm not going to present that because that's again another topic. But Sturge-Webers have the problem of the expulsive hemorrhage risk and shallow anterior chambers. So you have to go with all the precautions, and you invariably have these hemangiomas, conjunctival, episcleral, or choroidal, and it could be circumscribed or diffuse. Glaucoma, thankfully, is 30 to 70%, and it is usually due to angle malformation. Plus, here you have the episcleral venous pressure increase. And because of these genetic understandings and the linkage of these genes with the syndromes, with the disease, there is hope on the horizon that with this genetic counseling, and if you can check these babies intra utero, you can give a better advice. And that's where we still need to go further. Thank you so much.
So thank you for covering the entire spectrum on anterior segment dysgenesis. So just a question to you and Sushmita both. Like, what is the difference between trabeculectomy of an adult patient or a primary congenital glaucoma and ACE and anterior segment dysgenesis? Are there any differences? Is there a mic?
Yeah.
Yeah.
For a trabeculectomy for a child,
Like mic and
for a primary congenital glaucoma done before 1 or 2 years, and an AST is normally done at these middle teens. They come to us at 15, 14, 13. So obviously the globe is well formed. The phonic shortening, the phonic space, the space constraint is not there, which is a problem in congenital glaucoma. And the iris, although there is correctopia and you have all these iris problems, the iris behaves. Huh? Hello? Hello? I think
mic is not working.
Hello? Is
Yeah,
that working?
Yeah.
Okay. So, one is that the space constraints are not there in ASD, and the iris, although it has all these problems of the from the transillumination defects and the hypoplasia, the iris doesn't behave as badly as it does in PCG because the wraparound iris configuration is not there. And invariably, the angles are better off, and that is exactly why they are presenting later. So very often you may not do a trab and trab, you can just get away with a trab. And but mitomycin C is required for both. Rest, I think it is that the spectrum itself is, since these children present late, they have a little better prognosis. As I showed you, two patients who have 10 years follow-up vis-a-vis children, although I don't have that much of a PCG follow-up right now. But those children tend to do worse with trabeculectomy than these children.
So one would be that I would always do a limbal based in a small child, and I would always do a phonics based in an adult because I'm always scared. I have no idea. They're not going to show on the slit lamp. I'm not sure of retractions. It's more likely that the ATO might give away. So one is a limbus based flap always in a child, and the second thing to remember is that the limbus is so stretched to actually go behind
Yeah.
a stretched limbus. So just before coming, maybe the week before, I was sitting out and my fellow was operating and I was called in. And she said, the sclera is so stretched that I can't really dissect and I'm so scared of going in. And I realized that it was so broad, at least 5 to 6 millimeters. So she had started from the end of the cornea like you do for, and she was in the limbus. I said, "You're here, that's why." So you
Yeah.
have to go back and do another one. So that broad limbus. So in a child, you have to start at the border of the blue and the white
Yeah.
to make your incision. A trab, I would start
At the
just
limbus.
behind the limbus and leave it up. So those would be the major problems with both,
So
of
you
course,
have to
very
really
thin.
make a larger flap because
You have
yeah,
to really look at anatomy very, very
anatomy very
carefully
well.
on
Yeah.
table
Yeah.
before starting. It's not like start at the
And I
cornea
have
and
seen,
make
like,
the
initially, I have seen some trainees doing because it cuts like butter. It has less fibrous tissue and more water. So you should be very gentle while making the flap, otherwise, it will just go through and through. So I think that
another
is one of the important,
There's
yeah,
lot of scleral thinning.
yeah,
Younger
loss
the
of
child, the
scleral
more
thinning
the
and
thinning, and the
that,
and
limbal stretching is
yeah,
so much.
limbal.
In fact, sometimes the IOP is totally normal because the limbal
Yes.
stretching has taken care of the pressures.
Yeah.
And when you open it, you'll find a 4 millimeter stretching or a 3 millimeter. And as you said, the blue white junctions are so
it's
distorted that you
very
have to come very posteriorly to search for the
Search for
Schlemm's
the
canal.
Schlemm's
Yeah.
canal. So yeah,
Another
you have to
small
really
thing
have a,
the other small thing
big
I've
flap.
started to do is use a guarded knife, 350 microns. I can't go below that. So I'm
So you're
always
using
sure,
guarded knife?
yes, I'm
Oh,
using a
okay,
guarded
okay.
knife, 350 microns for the sclera, because I'm
Yeah.
sure the sclera is not less than 350
Yes,
microns.
yes, yes.
And I cannot go beyond lower than that. And the flaps that are made are so regular.
You have any question?
Guarded knife here, anywhere, any store, 350 rupees, 400 rupees, any cheap, anything. I'm not sure. Huh?
So in aniridia,
I've never done it. I just do on, yeah,
so I
posterior
think
to the.
in aniridia, since there is limbal cell deficiency, it is mandatory to make the limbal based flap. Rest in PCG and all, you can still make Ponix based flap. But in aniridia, because there's a
Actually,
lot of,
that's exactly why we shifted to conjunctival frill because here we are
yeah,
in the technique which I do, I spare the limbus totally.
limbus.
So
Okay.
it is I call it a marriage of convenience between
And
limbal and
any
phonics based.
difference in the mitomycin C use? Same. Subscleral also?
People say 4 minutes. I've never done it for
Uh,
4 minutes.
no,
Max,
but
I'll
they
go
say
till
that
three
it should be
minutes.
subscleral also.
I do for subscleral
Yeah,
now.
subscleral
30
also. No,
seconds I
you
do
don't do.
subscleral, 30 seconds
Okay.
subscleral, and 2.5 to 2 minutes
So now I,
superficial.
yeah.
I agreed, but the only thing is, Sushmita, what I've seen when these children come for follow up after 4 5 years, sometimes they just never come back, and they come at 6 years of age. Their sterile flaps are tightly adherent. So now I started doing so wiping immediately and doing it for 30 seconds subscleral.
Later. So I'll start with my talk on killed, which this terminology has become very popular now. And as we know, the developmental anomaly of anterior segment can be divided as iridotrabecular dysgenesis, as we see in primary congenital glaucoma, Axenfeld-Rieger syndrome, and iridia, or it can be keratoiridolenticular dysgenesis. So this is the terminology which has been given, and it is basically because of the defect in the neural crest migration in the 6th and 8th week of gestation. So as we know that the neural crests derived cells migrate from periphery towards the center to form the iris stroma, corneal stroma, and corneal endothelium. And this migration separates the lens vesicle from the corneal epithelium, because both of them originate from the surface ectoderm. So in killed, the cell migration process is defective with resultant posterior corneal defects and opacities with or without iridocorneal or keratolenticular adhesions and cataract. So basically, there are several classifications, and this classification is quite useful. Dr. Ken Nischel has classified congenital corneal opacities as primary congenital corneal opacities and secondary congenital corneal opacity, because these conditions are associated with corneal opacities. So they fall into the category of secondary congenital corneal opacities. So Killed can also be categorized according to the type of dysgenesis. So it can be just iridocorneal adhesions, which is traditionally called Peters anomaly type 1. Second one is corneo-irido-lenticular adhesions, that is called the Peters anomaly type 2. So in type 2, we have lenticular adhesions as well, because the lens failed to separate. And then there are other categories. The lens separates, but then it becomes reapposed, or lens separates but fails to continue to form, or the lens fails to form at all, the congenital aphakia. So this is again a very severe kind of dysgenesis, and the prognosis is very poor in congenital aphakia cases. So now coming to Peters anomaly, it is rare, and the phenotype can range from mild corneal peripheral opacity to severe opacification involving the central 3 millimeter. So basically it is associated with a typical defect in the Descemet's membrane and endothelium with adjacent either iridocorneal or corneolenticular adhesions. Cataract may or may not be there. So basically why these arrest happens is, in type 1, DM defect may represent primary failure of corneal endothelium. In type 2, there is incomplete separation of lens vesicles from the surface ectoderm, or lens, as I said, lens can develop normally, but then it is pushed forward against cornea, causing loss of DM. There is other classification also where they have been divided into three groups: cornea with central leukoma only, cornea with central leukoma and corneal lenticular touch, and third is cornea with central leukoma associated with Rieger mesodermal dysgenesis. So you can have iridocorneal adhesions at the periphery also. So these are various classifications, and you can follow any of them. So just a little bit about Peters anomaly type 1. So it may or may not be associated with glaucoma, because only 50% of the patients have glaucoma. So the opacity may be central eccentric or less commonly total, and it is invariably avascular. So the differentiating point is that there is no vascularization here, as opposed to Peters type 2 where there is vascularization. I am going to show the pictures. There are iridocorneal adhesions. Again, there will be no corneolenticular adhesions, and the mutations seen are PTEX2, FOXY1, CYP1B1, and PAC6. The prognosis is better because the lens is separate, and the results are PKP are good. So UBM offers valuable information about these situations, these conditions. Type 2, there is usually vascularized central or corneal, total corneal. As you can see, the vascularization is coming up to the center. So in UBM, you will see the cataractous lens with the anterior lens capsule not discernible at the point of attachment, and the mutation is FOXE3 here. So the prognosis is not so good. These are some of the pictures. As you can see, there is lenticular corneal adhesion here, complete loss of Descemet's membrane, and the lens is attached to the cornea, which is beautifully seen in UBM pictures here. Third condition is lens separates, but then again becomes reopposed. So, what is the pathology is that there could be hypoxia or persistent fetal vasculature pushing the lens forward onto the cornea, or it can be associated with aniridia with very shallow anterior chamber and keratolenticular touch. So here the surgical removal of lens, when the lens is attached to the cornea, you have to remove the lens, do the cataract surgery, and allowing the recovery of endothelium on its own rather than primary corneal transplantation. So first you do remove the lens and just let the cornea recover on its own without peeling off the anterior capsule which is adherent to the cornea. The fourth situation is where the lens separates but then fails to continue to form. Again, there is corneal opacity, and you see in UBM there's hardly any space between the cornea and the lens. Again, here since there's a complete fusion here, concomitant PKP with vitrectomy is needed. However, the success rate is low. Other condition which we get to see, although it is not very common, is where the lens failed to form at all. So here you can see the silvery hue appearance of the cornea, which allows transillumination, and the eye may be micro-ophthalmic because, as we know, and Sushmita also said in her presentation, that lens is instrumental in developing and promoting normal corneal growth and the anterior segment structure. So if the lens is not developed, the entire anterior segment structures go haywire. And the mutation is FOXE3 again, and again it is diagnosed with UBM. And one should be very careful in touching these eyes surgically because they can go into phthisis because of the formation of thick cyclitic membrane. So it is always better to manage them conservatively or with very little intervention. Peters plus syndrome is associated with systemic anomalies like cleft lip, cleft palate, developmental delay, short limbs, broad extremities, etc., along with Peters anomaly. So these are the conditions which have a lot of overlap, but we do see them and diagnose them with the help of ASOCT and UBM. Genetics, they are associated with the abnormalities or mutations in the genes like FOXY1, PITEX2, and PAX6. So these are called homeobox genes, and these are the parent genes which are responsible for formation of the anterior segment structures. So if something is abnormal in these genes, then the entire anterior segment gets dysgenetic. So glaucoma doesn't happen in all the patients in Peters anomaly. It is 50 to 70% may appear later, and elevated IOP could be because of trabecular dysgenesis if it presents at birth or during early childhood, or later on because of the closure of the angle because of iridocorneal or corneolenticular adhesions. So there's one series wherein 34 out of 58 eyes developed glaucoma, 2.8 years, plus minus 6.4. And glaucoma is more common as expected in type 2 because there's a lot of dysgenesis there. And some of these eyes, out of 34, 20 eyes required glaucoma surgery, and the child may require multiple glaucoma surgeries. And here they suggested that the glaucoma drainage devices had the best success rate, 53%, and cyclophotocoagulation had 67% chances of success. Trab with mitomycin C was not very successful, and 15 eyes they underwent glaucoma surgery uh, with GDT and cycloablation accounted. So these children have to undergo multiple surgeries. So just a few cases. So this was a 6-year-old boy. He had corneal lenticular adhesion in the periphery with peripheral corneal opacification, and the pressure was slightly high. So this was a mild case or Peters type 1, which was just managed as of now with the conservative treatment. It has to be differentiated because this particular child has a complete corneal opacity with a buphthalmos. So it's very important to do a UBM to see if there is any anterior segment dysgenesis, if there is any adhesions, the iridocorneal or lenticulocorneal. If there are no adhesions, as you can see here, the lens capsule is intact. There is absence of iridocorneal adhesions. So this is a simple case of PCG, which responds pretty well to trap plus trap. This very interesting case which we encountered, which came to us 3 to 4 months back, he was a full-term normal delivery. Birth weight was good. There was no, delayed crying, or the pregnancy was uneventful. The pressures were high when he presented to us 10 days after birth. And this was the situation. You can see the clearing of cornea in the center rest. The entire cornea was opaque, and the corneal diameter was more in the right eye. In the left eye, it was okay. The axial length was also high in the right eye. The pressure was also high. So this Peters anomaly was associated with congenital glaucoma. So this is the UBM picture. At one point, I could see this lenticulocorneal adhesion, and therefore I thought it's Peter type 2. And in the other eye, although the AC was very shallow, but there was no adhesions of the lens, and the normal lens echoes were seen in the UBM. The pedigree analysis showed that there was no one in the family who got affected. So type 2 Peters anomaly in right eye and type 1 in the left eye. And I just took up the child for trabeculectomy, thinking that I won't be able to do the trabeculotomy, but somehow I could pass a trabeculotome through the Schlemm's canal. You can see the fluid coming out from here, although it was very difficult. So, but this child right now, in terms of IOP control, is doing well in both the eyes. Both eyes, strap plus strap was done. Although he has corneal opacity and some delay in the development, which needs to be tackled with. Another case where there was complete absence of the lens. So again, in most of our patients, consanguinity is present, because we get patients, mostly Muslim patients, who have consanguineous marriages. And the mother was positive for rubella and HSV, and the child was also positive rubella and CMV. So in one eye he had microcornea with sclerocornea, and in the left eye he had bleophthalmos, as you can see, with silver hue appearance. And this is the UBM picture. UBM is very, very important. Again, I'm emphasizing, and there is no lens echoes which are seen. And in this B scan also, there were no lens echoes seen or PC noted. And one eye was micro-ophthalmic, 11.62. The other eye had the axial length of 14.25. So the diagnosis of both eyes congenital aphakia was made. So we have just put the child on conservative management right now, because the prognosis of doing surgery in such eyes is really, really bad. And these are the reports. So the key investigations for anterior segment dysgenesis is, I would say, along with the glaucoma assessment with tonometry, gonioscopy, the ultrasound biomicroscopy or ASOCT, and B-scan ultrasound to measure the axial length, because some of them may be associated with microphthalmia. And for each of them, the assessment with pediatrician is very, very important. Role of UBM, you can see the absent Descemet's membrane, defect in the endothelium, here bridging Descemet's membrane, and here you can see the iridocorneal attachments here. And here you can see the iridolenticular attachment in this patient. You can see here, and you can see here the central cornea which is attached to the lens. So I think all these clinical features can be very well delineated with UBM. So I would say you should have UBM if you are practicing you're practicing pediatric glaucoma. And the molecular diagnosis again is important, although it doesn't decide about the treatment. The management will remain the same, but it's important that you know about the genes, which is useful. I'm going to ask Sushmita in which cases you order genetic testing. And also, taking a good family history and pedigree helps direct the correct suspected molecular diagnosis. So pedigree testing is very, very important, where you will know whether it is the autosomal dominant or autosomal recessive inheritance, and you can even screen the parents. Sometimes the parents do not report, because autosomal dominance has variable expressibility, So the parents may not know about the disease. So if you do the pedigree charting, and if you find the inheritance pattern, then you can even screen the parents. And sometimes we have found that the parents have some amount of, dysgenesis in a child who presents with congenital glaucoma. So the management, again, with medical management or surgical optical iridectomy, especially in Peters anomaly where there is central corneal opacity, you can just do an inferior iridectomy. You may not do a PK, and then the treatment for glaucoma, whether medical or surgical, depending on the status, and symptomatic management of various systemic manifestations. It's a multidisciplinary approach, and a referral to the pediatrician is very important, and to a pediatrician or a counselor who is familiar with the developmental surveillance and intervention in young children with visual impairment to optimize development. So this is the chart in one of the papers where how to manage Peter type 1 and 2 when they present with the corneal opacity. In mild disease, you just can observe. In moderate disease, you can do optical iridectomy. In severe disease, you have to do PKP, and if the lens is attached, you have to do the lens extraction, and plus minus vitrectomy, and finally PKP. So you have to weigh the risk versus the benefit, and you have to talk to the parents about the prognosis and the need for multiple surgeries for these children. Some of them have poor prognosis. Thank you very much. So the question is whether you would advise, like which cases you would advise genetic testing.
So we are lucky that genetic testing is now so affordable. Clinical exome sequencing to us costs about 15,000 rupees. It tests across 6,500 known genes for disease. The thing to remember in genetic testing is just an abnormality in a gene is not enough. It has to be followed up with a Sanger sequencing because you have to do PCR of that variant. And if it's homozygous, it's okay if it's autosomal recessive. But if it's heterozygous, then the parental thing has to be done because you have to be sure that a heterozygous is coming from either parent. There might be wildcard entries as well. Having said that, I think for most it has helped in the sense that there have been so many surprises. It's made us very poor clinicians once we start doing the genetics. I'll illustrate a couple of cases in my next talk. So I think as things stand now, until we are very, very sure of the deep phenotyping. So we've started off with, of course, everything being congenital glaucoma to recognizing that everything is not congenital glaucoma, and that's why the CDRN has come in. But the phenotype is so important. We would miss systemic considerations, we would miss pediatric referrals, we would miss so many things if we didn't phenotype it better. And the only way we phenotype is better if you know the genotype. So I would right now, if affordable, do it in every child. Once we've done the genotyping, we've caught hold of parents because remember, these are young people. A lot of JOAGs have been caught simply because the kid has an autosomal dominant. You come here and sit down. Pressures of 30, 35, never known, young 26, 28-year-old. So, in that sense, the genetic testing has helped us a lot. The parents of the bachas who've come,
Siblings and the parents. Yeah.
they had high pressures because we sat them down and said, this is autosomal dominant, and let me see if you have anything. And they turned out to be
We
Axenfeld
had a very
unknown.
interesting case. We did a PCG child, and when I was operating her, the mother came in to pick up the child, and another surgeon who was retiring, she said, "I've operated this child, this lady as a child," and that lady had hidden all that from her husband and everything, and she had never come back for a follow up, and she was operated trab and trab. So it was such a revelation. One question to Dr. Sunita, like you said, the speakers, they have problems, they can the vitreous, you don't want to intervene. What is your you see it very rarely, but what is your take on just doing a dialase cyclophotocoagulation for them for control of pressure, because vision gain may not be much.
and if the lens is not there,
Yeah.
then you cannot, I think it's
Don't
not
want to
advisable to do
don't
any
want to
invasive
intervene.
surgery. They invariably land up in phthisis. I have seen one of my patients, I think she had undergone multiple, but ultimately she became physical. So yeah, limited
Limited
TSCPC,
TSPC or
DLCP is, I
DLCP
think,
can work even for
yeah,
the ones with not the aphakia, here, even the ones with the lenticular touch, because
yeah.
the cornea people are not going to operate this
Yeah,
child.
I think we take an
So
opinion from cornea
we
people.
can do that
If they do
procedure.
not want to intervene, then there's no point
There's
in
no
doing a
point in your
glaucoma
doing a
surgery
glaucoma
also.
intervention.
Invasive.
Yeah.
I think there are some patients who have
We
very
have to take up
advanced glaucoma,
next
very ophthalmos, huh?
next talk.
Yeah,
We have to
next
take up.
talk. So for Sushmita, the next
Next talk.
talk. No, no, I think it is better do unilateral if you know there are chances of, because you're never sure about the prognosis of the surgery. Yes, yes, yes. During EUA. Yes, yes, EUA you have to do. Yes.
Right. So, should I start the next one?
Yes,
Yeah.
yes.
Okay. So this is the last talk. So we can
No,
have lots of
one
questions. There's
interesting
one more.
cases
Okay.
also. Yeah.
Right. So
No, it is
there are no
115.
financial disclosures.
115.
Aniridia is classically an autosomal dominant disease due to PAX6, and it's a panocular disorder. It's not just an anterior segment dysgenesis. This is one of the spectrum in which everything can be affected: the iris, cornea, trabecular meshwork leading to glaucoma, the lens leading to cataract and lens subluxation, like here, and foveal hypoplasia and optic nerve coloboma and hypoplasia as well. So everything because of the PAX6 can be deranged. The pathogenesis is a complex interaction of the surface ectoderm, the neuroectoderm, as well as neural crest. So all three layers are affected. The ectodermal theory says that there's failure in the optic vesicle rim development between 12th and 14 weeks of gestation. So this is what causes aniridia with other ectodermal defects. Anomalies in the retina, absence of fovea, absence of iris musculature is because of ectodermal. The mesodermal theory says it's because of inadequate migration or proliferation of mesenchymal elements during the second month, and these are the aniridias with hypoplastic discs. Whereas Beauchamp et al. Actually said aniridia is explained in part on the basis of excessive remodeling and cell death. So if they're deranged, some are hyperplastic and some are hypo. The phenotypes, it's important to understand, are isolated aniridia without systemic involvement. That's the ones that come to us usually. The variant is in the PAX6 gene on chromosome 11p13 or a deletion. They could be autosomal dominant, 2/3 of cases, or a sporadic form in 1/3. So the parents could be completely normal. There's, of course, the Wilms tumor, aniridia, genitourinary abnormalities, and mental retardation, the Wagner syndrome, where are larger deletions affecting the adjacent WT1 gene. So WT1 is sitting very close to the PAX6, and therefore, if it is in that region, the WT1, which is the Wilms tumor gene, and the PAX6 may be deficient together. Then, of course, there's one more. There's Gillespie syndrome, which is associated with cerebral ataxia and intellectual disability. There's circumpupillary aplasia leading to a fixed dilated pupil, and that is pathognomical for the Gillespie syndrome. So, the genetic basis, the pathological allelic variant, you have 300 PAX6 mutations so far, which have been described. And the aniridia phenotype may be a result of all these kind of mutations in the PAX6 gene itself. So, it's not enough just knowing that there's a variant in the gene. What the variant is will also decide on what your phenotype is going to be. So, this is what I was saying, the PAX6 and the WT1 very, very close to each other on the 11p chromosome. So, if there is a variant, if there's a large enough variant, it might involve both of them together. I'll just get you through some clinical challenges that we see. This is case one. This 5-year-old boy comes to us with diminution of vision since childhood. The birth history was normal. And the family history, they said there are similar complaints in the family. So he has nystagmus, but the ultrasound of the abdomen has no neuroblastoma. So, nephroblastoma. So these are what he's like. He's 6'12, he's 15 and 18, so the corneas are all right. Corneal thickness is fine. The cornea is clear, but he has rudimentary iris, stretched zonules. The lens is subluxated superiorly. He has a pannus inferiorly, and he has inferior conjunctivalization of the cornea. But he also has no fovea on the red free, and the OCT is a little weird because there's nystagmus, remember. So this is a moving image, but we still managed to image the fovea, and you see there's no foveal contour at all. So there's complete foveal hypoplasia as well. Then we call in the family and we realize there's a mother, two brothers, and a sister are all affected similarly. So all of them had identical phenotypes, only the father was normal. So this autosomal dominant, just the mother having the PAX6 variant can have the variant in the entire family. We did an exome sequence of the proband of the boy that came to us. Sure enough, it was PAX6, heterozygous, aniridia 1, autosomal dominant. So there was no question that the entire family would have had the same. And of course, the first thing you say is, please stop producing more children because all your children are going to have this. They kept having these children, hoping that the next one would be normal and the next one would be normal. So if on hindsight we had done a proband analysis on the first kid, the counseling would have been, do not have any more children because you're going to land up with now the whole family has a visually impaired problem. Case 2 is a 3-week-old preterm baby. This is at 28 weeks, bilateral hazy cornea since birth. There's no ROP, systemically normal, and no history of glaucoma in the family. So sporadic newborn PCG, and the pressures on EUA were 26 on just brinzolamide. CCT was 800 and 853, very, very severe corneal thickness. 9 and 9.5 millimeters horizontal corneal diameter at a 30-week preterm. Epithelial edema, corneal clarity, grade 3. Also, CEU, no iris really visible, but the lens edge is visible with limbal stretching. So congenital ectropia in UVA we thought, but also a lot of iris stretching, and you can see that the lens is visible. So on table, it was made a diagnosis of aniridia because we realized that it wasn't just PCG. Both eyes had a very high iris insertion, very few processes, 0.7 and 0.8 cup discs. Post-op, the cornea cleared, and then we could image him on the slit lamp better, and you can see the lens edge, you can see the stumps of the iris, and we thought, okay. But surprisingly, he had no nystagmus, his vision was fine, pressures controlled, and we thought we were fine. We've also started doing a flying baby ASOCT, courtesy Savleen in our department. So we all do flying baby OCT for our babies as well. So you could see the stumps of the iris and the lens is fine, and we thought it's okay, and the cornea is of course clear. So we did a clinical exam finally, and to our horror, it was a FOXY1. And now you have a FOXY1 complete gene deletion, which is a very, very severe FOXY1. And then we say, are we looking at Axenfeld? I mean, what are we doing? Now we reviewed the child again and retrospectively noticed, sure enough, telecanthus, flat nasal bridge, micronathia, delayed dentition, umbilical hernia, redundant periumbilical skin. And we missed all of this. We didn't look at any of them because we saw ophthalmos, we saw absence of iris, we saw newborn, and we said, okay, so this is aniridia. So aniridia is just absence of iris, but it can't be a disease, and that's one thing that these are slowly things that we are understanding and retrospectively looking at our mistakes and realizing how wrong we were. So this is now we call it an aniridia variant of Axenfeld, and we write it on our charts. Axenfeld aniridia variant, and we have things like that. Okay, so this is a case 2. This is actually case 3. This is a 2-month-old baby, again, cloudy cornea since birth, intense epiphora, photophobia. And under the microscope, this is what it is. So garden variety, Axenfeld, you can see stumps of the iris, you can see the lens edge, you can see. So obviously, again, aniridia, grade 4 corneal clarity. Cup-disc ratio, again, 0.7, 0.8. Absolute glaucoma, have to be operated, bilateral combined trab vitrac, 6 months, again an IOP rise, again an axial length increase, so bilateral limited DLCP done at 6 months. Then by the time we get a clinical exam, and to our horror now this time it's CYP1B1. Now we ourselves, and this is the Sangers which I was talking about, so this is a clinical exam sequencing that you'll get. And once you get this, you need to go in, take this variant, and they'll run a PCR through it. And this is a Sanger sequence which will validate the fact that this is exactly it. Now, this is R390H, arginine at position 390 being replaced by histidine. We ourselves have looked at something called neonatal onset congenital ectropion UVA as a severe variant of newborn glaucoma. And we've reported that it's not the same as primary congenital glaucoma because it's not trabecular dysgenesis alone, but it's also congenital ectropion UVA and high-risk hypoplasia occurring at birth. And these were all children who were less than 1 month of age at presentation. We went a step further then, took all these children and did a clinical exome sequencing. 90% of them had arginine 390 histidine. So R390H to my resident now is, ma'am, this is really, really bad. It's a very, very poor prognosticator. And this is what we missed. We missed congenital ectropion UVA in us, in our center, the people who had described it in the first place. Why? Because the iris was so hypoplastic that we thought it was aniridia. 10 months follow up, corneal edema cleared, the scar remains. This is typical of a CYP1B1 cytopathy. This is what Ken Nischel has now described. CYP1B1 cytopathy is pathognomonic, that the cornea is going to scar, but the edema is going to clear. And this is what happens. So he turns out to be neonatal onset CEO with severe iris hypoplasia, clearly visualized on this EUA once the cornea has cleared. Now you can see the ectropion UVA beautifully. So this is the ectropion UVA, and the iris is so hypoplastic that the actually ciliary process are seen. This is not aniridia. So the good thing about this is there's going to be no limbal stem cell deficiency. There's going to be no foveal hypoplasia. If you can take care, and we don't need an optical iridectomy in this child because there is no iris, and this part of the cornea and the lens are completely clear. There's no cataract, there's no subluxation, there's nothing. You just need to give him refractive correction, amblyopia therapy. This kid is going to see. So other genes in aniridia like phenotypes are, like we've seen, is FOXY1 and PITX2 cause Axenfeld, but aniridia like Axenfeld. PITX3 mutations most often cause anterior segment dysgenesis with cataract. So if you have a cataract with aniridia, look for PITX3. CYP1B1 mutations can result in severe iris hypoplasia, like I showed you. It may present as aniridia, but it's not aniridia. The disease is completely different. So to conclude, I'm now understanding that aniridia is not absence of iris. Classic aniridia is PAC6 related and a panocular disorder. And that's the aniridia that our textbooks and we've grown up with. But other phenotypes may present with an absence or a hypoplasia of the iris, and there are implications of associated abnormalities of different diseases which we need to. That's what I was talking about. Deep phenotyping is what is important. Thank you. And frankly, the more you learn, the less and less you know. That's something which I've understood. Thank you.
Excellent talk, Sushmita, as usual. So I think aniridia is sometimes very difficult to manage and it requires multidisciplinary approach. Even I think since there's stem cell deficiency, keratopathy and all, so I think we should even use preservative-free eye drops and lots of lubrication to preserve the stem cells. I think that aspect is often missed. And we do not, sometimes, we just keep managing on our own and we forget to refer to cornea and all where a lot of management is required, especially for the keratopathy. So I've seen the keratopathy progressing over a period of time, and you can, I don't know whether you can prevent it, but you can delay it by preserving the stem cells and all. So very
Problem is
nice.
preservative drops are so expensive
Yeah.
and not so freely available that the patient affordability becomes an issue with
Yeah.
that.
So we have last talk. Dr. Tripti is going to present two interesting cases of Exenfield Raker. Yeah, sure. You can ask. Yeah.
Mike,
Mike.
Mike, please switch on the mic.
बस चल नहीं रहा है.
It's not working. मैंने तो
ये ले लो कोई नहीं.
So they are young. They've come to me, say maybe a girl came to me, 13, 14 years old, and she had NRID. She had been going to some other place. Pressures were normal. Now, do I do genetic testing for this child also?
For the family implication, possibly, if you want.
Okay.
I mean,
So if
otherwise,
she's otherwise normal, has no high pressures, I don't really need to advise any genetic testing. Only from her passing on this condition to
exactly.
her
Very important.
that time.
Very important. Passing on, you would know, and you would come across. And now, I mean, it's early days yet, but I'm looking at each of my anterior segment dysgenesis, not just the genotype, but what the variant is. So someday I want to answer कि अच्छा इसका ये variant है तो उसका ये होगा. So that answer is going to come only if more and more of us do it. And it's not enough to know it's a PAC6, like 300 variants of PAC6. Each of
Which
those
one?
variant would have a different phenotype. Right? So in that sense, yes.
So I should do a CES,
Clinical exam sequence.
That's all.
That's all. And of course, you need to validate that with the Sangas along with it, but that's about
So
it.
if I just order that, they will do the Sangers also.
No, it depends on
You
the
have to
lab.
tell them?
You'll have to tell them they charge 2,500 per variant for us. So I've told them to combine the two, and then they charge 15,000 including the Sangers, but it's 13,000 without the Sangers. So you'll have to just catch hold of your
Okay.
whatever guy and
So as
But,
we
get
spoke
it done.
earlier, then just give me the
Sometimes I've
address.
observed, like, mutations will come, but sometimes if it is duplication or deletions, then it may not come in your genetic testing. So sometimes you feel it is sporadic. So for that, a lot of other tests are required. Copy, I'm just forgetting the name, but there are some other set of tests which are required and which are very expensive, up to 1 lakh rupees. So it may not be necessary. It is not necessary that it will show up, even if it is there.
At least rule out anything major if
Yeah.
it's come, but otherwise.
But get a family screening anyway, clinically a
Yeah.
family screening and the sibling screening done. That's also very important. Just the genetic may not be again available nor affordable. And the second thing is what I've seen, I mean, I deal a lot of low vision patients initially. If you try to identify, like what she said, the heterogeneous and it was a sequence, the husband will divorce the wife and he'll say, I'm not going to have kids with her, and he just dump her and go away. That's happened a couple of times, in not in my practice, but it's because this is the problem. We don't have genetic sequencing done anyway with us, but you have to be very cautious when you explain to that lady, if she has any genetic this thing, about the marriage counseling, and otherwise quality of life will be gone. That's also an aspect which we have to take care of.
Tripti, can start.
Good afternoon, everybody. I am Dr. Tripti, and I would like to thank Dr. Sunita
She is our fellow. So
to give me this opportunity. And thanks to all of you. Before my presentation, you have discussed many interesting cases. So I'll be discussing two of the interesting cases that I worked up. So as we have already discussed,
slides.
slides.
They were sitting only.
So, anterior segment dysgenesis is an inherited condition characterized by developmental anomalies of anterior segment. Many of the disorders also involve systemic abnormalities. About 50% patients of Axenfeld-Rieger develop glaucoma. PTEX2 and FOXC1 gene mutations are the known genetic heterogeneity, and recently mutations in FKHL7, CYP1B1, and PRDM5 gene have also been identified. Next. Okay. So coming to our case one, so it's a 13-year-old female who has been following up with us since the age of 4 years. And on presentation, the parents came with a complaint of nystagmus and alternating exotropia and a suspicion of glaucoma. So she had megalocornea in both the eyes, and examination under anesthesia was advised. And we found that the corneal diameter was 13.5 mm in both the eyes with a posterior embryotoxon, and a shallow peripheral anterior chamber depth in both the eyes. Axial length was within normal limits. IOP was 26 and 28 mm edgy in both the eyes, and cup disc ratio was within normal limits and CCT was also within normal limits. So after examination under anesthesia, diagnosis of axon field anomaly was made and patient was started on anti-glaucoma medications. And since then, the patient has been following up with us regularly. In 2019, her systemic examination showed oligodontia, and she had vision of 618 in the right eye and 66 in the left eye. She again had megalocornea in both the eyes, as we can see in this image, and a progressive peripheral anterior synechiae was present. And her IOP was 22 mmHg and 25 mmHg on 3 AGMs. And so this is the image of the right eye where we can see a posterior embryotoxin in this image and a loss of normal color and pattern of the iris. And over here in this image, we can see atrophic patches and thinning and pseudo holes present. Similarly, in the left eye, we can see an irregular pupil and an ectropia on UVA present with atrophic iris patches and a posterior embryotoxin also present. On gonioscopic evaluation, we can see a multiple iris processes and bridging synechiae and a disorganized angle structures. And similar picture was seen in the left eye as well. This is the fundus photo where we can see a bipolar thinning of the rim and a 0.9:1 cup disc ratio. But in the left eye, her rim was preserved with a healthy neuroretinal rim and a cup disc ratio of 0.5:1. So this is the IOP trend of the patient, wherein we can see the IOPs were not well controlled on maximum medication, and patient was advised to undergo trabeculectomy surgery in both the eyes eventually. So this is the OCT RNFL images of both the eyes of 2019 and compared it with the 2023 data, and we can see a progressive loss in the numbers of progressive loss of the RNFL in all the quadrants. Similarly, the similar picture was seen in GCC scans as well. And this is the visual field image of right eye where we can see an advanced damage, whereas in the left eye, visual field was well preserved. So this is the IOP trend after both eyes trabeculectomy was done, and patient has been doing well after trabeculectomy and on no AGMs. So we even advised genetic testing for this patient, and it came out negative for all the known gene mutations, and whole exon sequencing was done for this patient. And this is a pedigree chart where none of the family members were affected.
So I think patient, it was like nothing came out. It came out as a sporadic, although it's a typical axon field rigor syndrome. So sometimes I don't know, like it happens like that.
And whole exome sequencing, they only check for point mutations, ma'am, not for deletions or duplications.
Yeah, that is what.
And
Yeah.
only 60 to 70% of the patients come out positive for the known gene mutations. So there are so many gene mutations we are not even aware of right now. So coming to our next case, it's a 17-year-old male who visited for glaucoma opinion. He was already on timolol dorzolamide combination drops and prostaglandin analog in both the eyes. His visual acuity was 6/12 in both the eyes with a myopic refractive error. On systemic evaluation, we can see this facial profile with a maxillary hypoprominence and a flattening of the midface and a receding upper lip and a prominent lower lip. And in the side profile, we can see a micrognathia. And he also had a ambiguous umbilical skin tag. So on examination, his IOP was 23 in the right eye on 3 AGMs, and in the left eye it was 34 on 3 AGMs, and he had a high CCT in 650s in both the eyes. So this is a slit lamp image of the right eye where we can see a loss of normal architecture. We can see a correctopia, we can see stretch holes present and a posterior embryotoxin present with the peripheral anterior synechiae present. Similarly, in the left eye, we can see a larger stretch holes present, a correctopia and posterior embryotoxin and peripheral anterior synechiae. And on gonioscopic images, there was 360-degree pass with bridging synechiae, and similar pictures were also seen in the left eye. So in this, we can see right eye optic disc was well preserved with a cup disc ratio of 0.5:1 and a healthy neuroretinal rim, Whereas in the left eye, he had a bipolar thinning and advanced loss of RNFL and neuroretinal rim with a cup disc ratio of 0.9:1. So in this GCC RNFL, this is the images of GCC and RNFL where we can see the right eye images with the normal limits, whereas advanced loss is seen in both the eyes in the left. Advanced damage is seen on both the scans in left eye. And it was correlating well on the visual field as well. So right eye visual field were within normal limits, whereas in left eye we can see an advanced damage of the fields. So a diagnosis of Axenfeld-Rieger syndrome was made in both the eyes, and the patient was advised to step up anti-glaucoma medication for better IOP control. And IOP was controlled for some time, but then eventually it was uncontrolled, and both eyes trabeculectomy surgery was planned. So this is first the left eye surgery was planned because it had advanced damage, and eventually even the right eye IOP were not controlled. So right eye trabeculectomy surgery was also done. And this is the post-op day 1 image where we can see a diffuse bleb present in both the eyes. So the management includes parental counseling and education in terms of need for surgery, need for resurgeries, and management of the complications like squint or amblyopia or any keratopathy that developed due to this syndrome. Examination under anesthesia for severity of the disease and extent of glaucomatous damage is important. Treatment is both medical and surgical management depending on the age of onset, the severity of disease, progression, and IOP measurements. And more than 70% of the patient will require multiple surgeries. Surgical options include goniotomy, trabeculotomy, and trabeculectomy with mitomycin C and glaucoma drainage devices. In early onset glaucomas, trabeculotomy is favored over goniotomy due to presence of iris adhesions and a rudimentary Schlemm's canal. Mandal et al. Mandal et al. Suggests trabeculectomy as a reasonable option in failed angle surgeries. In refractory cases, glaucoma drainage devices have been reported to be successful after a failure of conventional surgery, and no laser procedure have been proven effective in treatment of ARS-associated glaucomas. So, in this paper, they have discussed surgical outcomes associated with Axenfeld-Rieger syndrome, and they concluded that 70% of the patients with ARS have secondary glaucomas that often require multiple surgeries, and trabeculectomy with MMC and Barwell glaucoma drainage devices showed greater suspect. So this is the table they had shown. In this, we can see trabeculectomy had success rate of 57%, and Barwell glaucoma drainage device had success rate of 70%. And whereas the other mode of surgical intervention has lesser surgical success rate. So this is a retrospective analysis of long-term surgical result and visual outcomes of early onset glaucoma in Axenfeld-Rieger anomaly, and they concluded that primary combined TRAB and TRAB is a safe and effective procedure for early onset glaucoma associated with Axenfeld-Rieger anomaly. And this is a recent paper where they have discussed that Zen implantation in Axenfeld-Rieger syndrome is also have a promising result. So this patient had Axenfeld-Rieger syndrome, and the other eye was not doing very well with trabeculectomy surgery. So the patient was apprehensive to undergo trabeculectomy surgery. So Zen implantation was done, and this paper shows that the patient has been monitoring well on uncontrolled IOPs. So to conclude, ARS is a rare genetic disorder with typical dental, facial, and ophthalmological clinical signs. And ocular defect in ARS are typically bilateral. Clinical diagnosis and management of pediatric glaucoma are guided by phenotypes. Genetic testing enables accurate genetic counseling, can reduce the risk of disease recurrence. And a holistic approach involves IOP management, both medical and surgical, and management of sequelae like cornea complications, amblyopia, squint, etc. Thank you.
Thank you for nice presentation. Like in these, especially in Axenfeld-Rieger, the prognosis for TRAB is pretty good. TRAB is because we do the TRAB later, maybe when the child is in the second decade or so. So it is good. Literature suggests that implants, but I never do implants as the primary procedure in these.
But that paper was showing goniotomy results to be pretty superior. 17%.
No,
And
No, no,
the
no, no.
GDD results were 70%.
The
Right?
GDD, but we don't.
43% for goniotomy, ma'am, and
Kitna?
43% for
Goniotomy
goniotomy,
may not be so.
and
43.
13%, 17% for trabeculotomy.
That's
This
what
is
trabeculotomy, and trabeculectomy
was 57%.
yeah. So
Trabeculectomy is good.
goniotomy and trabeculectomy was similar, but again, whatever little exposure I've had, goniotomy, would it work that well in axon field riggers?
No, no, I have not.
What
I
would
don't
you
know.
say?
Sushmita can.
If the glaucoma is later, if it's a child which is later with a clear cornea, then you assume that the distal channels would have developed something. It's a later thing. So,
You
I
can
mean,
try.
I am so scared of the conjunctiva, frankly, especially when I tell my fellows 1, 2, 3, 4, 5, 6 at the most, if you've done your senior residency also, they're all very well. You get your gray hair and see them in 10 years' time, and those conjunctivas are bad. So we are proponents of moving away from conjunctiva. Of course, telling the parent that I'm doing this because I know it's less effective, but it's safer. And if it works, well and good. If it works in even half, I'm quite happy. 43. I would have said 50%. If somebody had asked me, I'd have said half my older children with Axenfeld do okay. Younger children, the babies that come, combined trab with trab is required. They need outflow. I don't think distal channels would be there for just a trabeculotomy. And possibly, I'm surprised that the trabeculotomy, that the trab with trab hasn't worked at all.
Yeah.
That doesn't make sense. If it's 57,
Ma'am,
where
in
is
this
No,
paper they haven't
trabeculotomy or
discussed that, but
this paper doesn't have trabeculotomy.
yes, ma'am. This does
other
not have
one.
combined.
No, it has combined.
Combined
This
works
has
well.
combined, this doesn't have
Yeah.
trabeculotomy. So that's a little strange that they've done a
Yeah,
combined.
that's
So if a combined trab with trab is 17% and
that's
57% for only a trabeculectomy,
Ah.
to
It
me
did-
makes
it
no
did- it
sense.
did
I
Yes,
don't
yes, yes.
understand that.
but
Huh?
anyway, that's
No,
one.
sorry. It says trabeculotomy or combined. Oh, okay. So they've also
Plus
included.
minus
No,
trabeculotomy.
plus
Yes,
minus.
they've also included
minus.
only trabeculotomy. I don't think the two
Trabeculotomy
procedures.
may not work so
But
well,
plus
but
minus, just
trabeculectomy I
No,
have
but I
seen.
don't think you can combine them both
Yeah,
together.
yeah,
So
you
I would
cannot
say this is a
combine.
fallacy. You
Yes.
can't combine trabeculotomy and a trabeculotomy with trabeculectomy
Yeah.
in the same group. So I'm not sure about that. But
Hmm.
53% for goniotomy is fair enough. Is about half. If it is an older
No,
child
but there are
in the second decade,
iridocorneal adhesions.
you go above
you
that.
just
You go above that. Don't slit
Ah.
it. Go right above because the dysgenesis is
only
still
the
there.
trabecular mesh works. So
Yeah,
you just
so
are
just-
dealing with the
just that.
trabecular
Once you go above them,
dysgenesis.
then it falls back, and then you can see the trabecular meshwork in there. Yeah.
It falls back. Just
So you
above.
would try it till what age? You said younger one you would not do it.
No,
So
no.
what's the cutoff?
So
4
if
years,
they come
5
usually
years?
the second decade, the 10, 11, 12-year-olds,
So
where
you
we
would
do
try
only a
that. You would
trabeculectomy.
try. And you
So
want to
before
wait-
the trabeculectomy, I would do a.
And if the response comes, it comes immediately? If the
after
response
what?
has to come.
After goniotomy?
After
Yeah, the
goniotomy.
usual.
Yes.
4 to 6 weeks, whatever you see.
So
the
then you
usual.
don't, if it then doesn't work in 1 month's time or 2 months' time, you go and do it surgery.
As and when required.
But I have
would
seen
do
in
that.
my practice trabeculectomy with mitomycin because they are older children.
Yes,
Same
they're
here.
older
Same
children.
So
here.
I think
Same
they,
here.
it
But I
works
would
reasonably
combine. I
well.
would combine with the trabeculotomy
Ah.
always.
Yeah.
If I have a dysgenesis, I would not leave it at
It's
trabeculectomy
just
alone.
trabeculectomy.
Even the
Since I'm
older-
giving GA, I'm
Even
giving
the older
everything,
child.
I would, even
Yeah.
in older children,
Yeah.
do a combined trab with trab.
But I never understand, like after 10, 12 years of having glaucoma and dysgenesis, whether it can be corrected. Well, you have to make an alternate channel with
Meaning, what she's
trabeculectomy.
saying is you do a
Just add it.
trabeculotomy addition.
Addition.
Always.
Give an
Even in
additional
older
thing.
children.
Additional,
Even
Even
I do
in
the same
older.
thing. Older children, maybe once you're entering it,
Yeah,
it's
once you're
Yeah,
entering,
it
you
is
might
not,
as
it's
well
not a
do
big
it.
deal. You
Cut
can
it,
just,
yeah. And it's easier sometimes in older children. Younger children, it's worse off. In
Yes,
older,
yes,
it's
yes.
easier
Because
to
the anatomy is not so
It's not
distorted.
so distorted.
Because the IOP hadn't risen initially. It's a late onset IOP rise, obviously, because there's no ophthalmos. The cornea is reasonably clear. So it's a more JOAG
Yeah,
kind
yeah.
of
Yes, yes, yes.
whatever phenotype.
So thank you.
Thank you, ma'am.